Hello everyone, I'm Dr. Akshay Kumar Kamble, and with me I have Dr. Santosh Rai,
Hello.
who is working as a consultant radiologist in NHS Trust. He's running a FRCR course for last 15 years successfully. And in last episode, we saw he did an introduction about how to go about FRCR exam. And in this session, he is going to act as a candidate and to show us what a smooth exam would go. So we are grateful, Dr. Rai, for you to agreeing to participate as a candidate. It must have been a while since you have been another uh, other side of the table. So without any delay, we should start, if you don't mind.
Okay.
Yeah.
Thank you.
So this is the patient who presents with right groin pain, and uh, this is the radiograph.
So, thank you. And this is a frontal radiograph, which is of a hemipelvis, which shows the right hip joint and the right pelvic bones. I could see slight deformity of the right femoral head, which shows to me slight flattening and some area of sclerosis on the upper surface, saying that the joint space is well maintained and the femoral neck is normal and the proximal shaft, I think, is normal. The lucency in the lesser trochanter is possibly projectional to me on this view, but I would like to confirm on other views if this is persistent or projectional. The other thing I could see in the film is a rounded sclerotic opacity overlying the right iliac fossa, which is on this view projected on the right iliac bone. There is a surrounding lucency and a ring-like structure at this level of the sclerotic lesion. The bowel gas pattern visible on this film is looks to me normal. I could not see anything in the hernial orifice projecting. Uh, so I would be wondering whether this patient has something done like a colostomy in the right iliac. Is the patient has something done?
Yes, patient has a history of colostomy.
Okay, so some bowel disease, maybe colostomy done. So with that in mind, I will try to link these two findings, and I think the lesion in the femoral head is possibly avascular necrosis of the femoral head, possibly from a chronic GI uh, disease, which he must be on steroid, like Crohn's or ulcerative colitis, which has led to colostomy. And I would also review the previous imaging just to make sure that this hip was pretty okay and this finding is more new due to the pain. And also I'll confirm the lesser trochanter as to be a projectional view. So
What would you uh, advise as a management?
I think because the patient has some chronic GI problem and developing groin pain, which is not related to the GI thing, it is related to GI, but it's mainly a musculoskeletal problem. I'll refer to orthopedics uh, surgeon to see if they want to follow this patient up and see if there's any other further management for that.
Okay. We'll move on to the next case. This is the old lady who presents with a chronic knee pain.
Okay, so again we got a single view frontal radiograph of a knee on an adult patient. As you said, is an adult old lady. I could see there is a loss of joint space bilaterally on both medial and lateral aspect. Calcification within the menisci noted, which is in keeping with chondrocalcinosis. Bilaterally, both medial and lateral, there is marginal osteophyte both on the medial and lateral condyles, and even the plateau on the medial side. So there is moderately degenerated knee joint with spiking of tibial spine. There's some opacity seen at the level of the upper tibiofibular joint, which I think is possibly either degeneration or need to make sure it is not loose body. So ideally, I would like to see both projections when I do reporting. So AP and lateral, which is my normal practice. If there is, it will be beneficial. If not, this is looks to me is a moderately degenerated knee joint with chondrocalcinosis and suspicious loose bodies. There's no erosions I could see.
What are the differentials in this case?
So the differential of chondrocalcinosis would be, firstly, is it can be in a degenerative disease like old age and idiopathic. The other thing is pseudogout is quite common. That is crystal arthropathy. In that case, I could not see any obvious other erosive changes around it. It can also be seen in gout. Again, there's no erosion to see why it is not gout. Wilson's disease, but the patient is a bit old. That's one of the other possibility, and other metabolic conditions if there is history for that. Ideally, I would say it is idiopathic in this case or age-related degenerative knee with chondrocalcinosis.
What would you advise in the management?
I think this is a chronic knee pain because the patient is old. Chronic knee pain with moderately degenerative knee. I would refer to orthopedics surgeons to see if they want to either do a pain relief or maybe take it further by knee replacement, depending on the criteria and the patient's ability and fitness levels. So that is from radiological point of view, I'll refer to orthopedic surgery. No need of doing, I think, further imaging in this lady because there's no other suspicion I have.
Okay. So we have a young adult male who is presenting with acute back pain.
Yeah, again, we got a focal single radiograph, a lateral dorsal spine location. And I think I couldn't count the level of whatever, but I think there is what I see is a loss of disc height at the level shown. There is loss of disc height. There is some erosive changes in the disc with some sclerotic along the end plate margins of these erosions. There is some spurring in the anterior part of the vertebral body. The alignment otherwise is well maintained. The disc above and below looks to be normal. The end plates are normal. And the facet joints are normal. The pre-spinal space, soft tissue, difficult to assess but does not show any obvious abnormality at this level. With this acute back pain, I think as you said, I would say that this is possibly a discitis, which should be a worrying point. And I think we need to first look at the whole spine X-ray, epilateral, or do a MRI scan, definitely to further assess this. If I can,
What are you suspecting in MRI? What findings you're looking for?
I think MRI scan we normally traditionally we do T1, T2, and stir sagittal image and axial image at the site of abnormality. And I think I'm looking for possibly brightness at this disc level, which is my suspicion of discitis. So if it will be bright on the stir sequence, I would be highly suspicious of discitis. And this is my worry. In normally, if there is a gadolinium also, that would also be helpful to see any abscess formation. So I think we have been given a T1 and a post-gadolinium MR on the same patient. And I think the abnormality shows on T1 as irregular loss of disc height with irregular end plate and a low marrow signal changes or low signal changes at the adjacent vertebral body, a small prevertebral isointense soft tissue enlargement. I could see the cord behind, so this is at the dorsal lumbar at possibly is L1, L2 level, what I can see. And the conus and the cord looks okay. The aorta is normal. On post GAD, I could see intense enhancement at the disc level, and there's a small area of abscess in the prevertebral space, which was seen on the T1 as a soft tissue enlargement. So there's a small abscess in the prevertebral. I could not see any obvious epidural component or epidural abscess. The cord and the spinal canal is intact. So this is confirms my diagnosis of discitis, which I thought on the plain radiograph as the diagnosis.
What would you do next?
So next would be to refer to a spinal surgical team in view that we need to know the organism, and I think they need to biopsy this disc or the abscess to find out the organism so that the proper treatment is given. Because there's no epidural component, there is no urgency to decompress or something like that. So ideally, one should do a biopsy and take it further from there. So urgent spinal surgical referral would be uh, my referral for this.
Okay. This patient presents with a history of fall.
So frontal radiograph, which is AP view or DP view of a right hand. I could see abnormality in the proximal phalanx of the right index finger. There is a well-defined rounded lucency, which is expansile, with endosteal thinning seen in the mid shaft of the proximal phalanx. I could not see any obvious soft tissue extension or cortical break at this level. The lucency as such is clear with mildly sclerotic margin, well-defined lesion with a narrow zone of transition. It's a benign lesion which is expansile, and the rest of the bones visible in the hand are normal. I could not see any obvious abnormality in the MCP or the interphalangeal joint, no erosions, no soft tissue calcification. So I'm thinking of a benign lesion involving the proximal. Because there is a history of fall, I think this is an incidental finding. And given this narrow zone of transition incidental, I would think to see whether I have previous radiograph to see whether I could see this lesion before and is there any change in it. The second thing would be that this is a benign lesion and most likely in hands we see this as enchondroma, uh, as a lucency.
So, what would be your differentials?
I think the differential in this is like because it's benign lesion, the other possibilities like fibrous dysplasia. If it's a young patient, I will think of eosinophilic granuloma. Uh, Lytic lesions with Mets are there, but which is statistically more common, but you don't find Mets below elbow and knee as commonly. So, and this is a very narrow zone of transition, so that will be very low in probability. So I'll still keep as enchondroma as my possibility. Look at the previous films. If it is there, then it makes it think that this is a long-standing lesion and incidental finding. If there is a patient has pain because he come with a fall, sometimes they have a potential of a cortical break, which you can't see on the plain radiograph. I would advise an MRI just to make sure there's no soft tissue extension or a cortical break, which could be the reason of the pain. And that's what I would try to advise if patient is still symptomatic.
And if patient is not that symptomatic, what would be your management strategy?
I think because it's the incidental finding, we don't know if there is a previous radiograph. We know that we are looking at a benign. If not, then we'll follow it up in 3 to 6 months' time with the plain radiograph to see any changes and take it from there. That should be the ideal way of managing this lesion.
Okay, I think we'll go to the next one. 25-year-old male patient presents with a painful wrist swelling.
Again, single view of the wrist. I do not see any side on that, so is a AP wrist joint X-ray. The abnormality is based in the distal radius. There is a subarticular expansolytic lesion, eccentrically situated, with cortical thinning on the radial side. There is a bit of the zone of transition, not very clear proximally, but I think it's a narrow zone of transition. The outer cortex is very thinned out. I cannot be very sure whether there is a breach in the cortex or not. There's some lucency within the lesion also. I could not see any breach in the articular margin on the radiograph. The proximal carpal row and the carpal bones looks normal. There's a slight low place ulna. I would also see the other view, lateral view, to make sure this lesion is not breaching the frontal cortex of the radius. And so again, the location of this lesion being subarticular eccentrically expansor lesion, most likely diagnosis would be GCT, a giant cell tumor, which is a benign condition. And I will look at the other views also.
What would you advise?
I think one should do an MRI just to make sure that there's no soap bubble appearance of a ABC fluid level, which is a bit on a younger age group. We see ABC and cortical breach, and also if there is any other possibility, and look at the proximal part of the radius also. So MRI would be the best way to take it further and suggest an orthopedic referral if it is not coming from orthopedics referral.
So that was the end of today's exam. And how do you feel? You have done?
Oh, great. So, guys, this was actually to give a flavor of because I think we give a flavor of how the exam can be set up. Like this is what the exam is. You can get about 7 8 films because this were more clear cut description. We wanted to show you how to describe the film, how to radiologically you describe the finding and then look at the observation, come to a principal diagnosis which you know. It was trying to show that you can ask questions to the examiner, like in the first case, the colostomy, whether there was a colostomy or not, and a patient on immunocompromised steroid, you can ask relevant questions depending on the case to the examiner. Don't feel like be afraid of it. And if it is given, then it gives you a point of direction when you're running away from benign to malignant, the examiner may help you uh, and maybe shift you to ask you or make you push to see whether you are very sure of being a benign or a malignant lesion. So it's not that he's not trying to disapprove you, but he's trying to make you feel like either you're confident of what you're talking about. So this is what a normal exam, and then once you come to a diagnosis, if it's clear cut, the examiner should move to the next film. If not, then he will ask you more questions. When they ask for any other exam or modality to be done, then you should know why you're asking MRI or CT, because they will ask you why you need that, because everything has a cost to it. So you should know why you're doing it. You should know the management of the cases, like whether it should be referred, MDT, or it should be operated or it should be not operated. It should be treated like in the case of infection, biopsies or not. So things like that is more important. So once the management is, I think, discussed, I think you would be clearly past the films. So this set of exam which we showed you is like a clear. If you get through this way, you have passed all the films, and this is where our objective was to show you. And it's not very daunting; it's very logical approach, description, trying to concise two findings to one, common things in uncommon situation, uncommon things in a common situation, things like that. Things of common thing first, and then come to a diagnosis. If you have differential, give. If you don't think, don't give. If they push you to ask, you should know why you think this is the main and why this is not the main one, and then take it from there.
Yes, and also uh, when you are giving exam, don't expect examiner to give you any kind of feedback at the end of the case. The case will move on to the next case.
Yeah, that's true because I think you need to make sure you're told it. You give some time. If the examiner is happy, and some examiners will try to push you and then keep on the film to make sure you are firm. Some examiner will just move on to the next film, and it shows how confidence. And I think they also judge you if you are good in one or two films. They will know that you are quite firm and you know it. Some films will be tough. It will need a lot of logical discussion and logical approach with a lot of differentials, and I think you should know you should argue around the differentials, why this and why not. So you should have
Yes,
some idea of differential in your mind. You have a young patient with lytic lesion, old patient with lytic lesion, the site of the lesions. You should have few differentials in your mind. Sometimes it's difficult on the hot seat to get all the things out, but the more you practice, the better you will become. You should make some list of things like in bones, in chest, like fibrosis, upper lobe, mid lobe, lower lobe fibrosis, nodular opacities, cavitating nodules. Similarly, in bones, ground glass appearance, lytic lesion, epiphyseal lesion, metaphyseal lesion. If you have that made up, you revise it, you'll be okay at the time of exam.
yes, and also you don't have to give differential list of all the differentials, only the pertaining to that case, depending on the age of the patient, how the appearance is demonstrated in his description. That you can rule out many things while giving the description, so that your examiner knows that your approach is correct.
Guys, the main aim was to give you a sample area of
Yes,
viva exam. The next episode, we'll try to have vivas which is real, maybe a bit difficult
yes,
cases, easy and difficult, how to go around with it. Some of the things, episode we'll just do some teaching films which are shown in exam, that how you approach this film and what are, we'll maybe make it more of a teaching. We would like you to comment on what you think about this. Is it more helpful? And whether this is helpful or the teaching methods are helpful, and we want to know from you what really you need, because every candidate has a different requirement. I think we want to give you flavor. We want to show you some films which are shown in viva. The main aim was to how you approach a film, how you go around with it, and it's nothing more of a rocket science. It's very simple,
yes,
but on the hot seat, you have to keep your mind calm and cool.
yes,
That's what
yes,
our aim was.
yes,
So wait for the next episode. Next, we will keep going and give you more flavor of more films, more difficult cases,
yes,
and things like. We are done skeletal just to describe. Now we'll be doing some neuros and other modalities. Then we'll mix and match also, and cases, and take it from there, because exam will be more mix and match. Yeah. Okay.
yes. Thank you
Thank you
all.
guys.
Thank
And
you.
please subscribe to our channel,
Yes,
and press the bell icon so that you get the next episode known, so that you don't miss it out. And
yes,
thank you.
yes.
See you
Thank
later.
you all.
See
See
you.
you.
See you. Bye.
Bye bye.